What did one elevator say to the other? Needle lift? Oh, that's good. I like that. Needle lift. Hello? Check, check, check. I think my batteries might be out. I think I'm coming down with something. That was the answer to the joke. Oh. I know. The punchline's dragged out isn't as funny, is it? So, what did one elevator say to the next? Right? I think I'm coming down with something. So that's the joke. All right. AV difficulties make this difficult. All right. What I want to do is change this mic, and I want you to work on this question. Thank you. Thank you. Appreciate it. Parasympathetic division. Think about what it does and what it's responsible for. And take a look at the responses that are listed on the screen. So A. Am I on? There we go. Hello? A. Decreases blood flow to the skin. B. Mediates any reflexes that regulate the digestive, urinary, and reproductive systems. C. Is responsible for the fight or flight response. D. Causes an increase in metabolism. Or E. All of the above. What do you guys think? Who's got an answer? Raise your hand. And can you defend it or explain it? Up front. B because of why?
Because A, C, and D describe the sympathetic nervous
A, C, and D are all sympathetic nervous system. Okay, very good. What I want you to do is I want you to do a little drawing here. I want you to create picture A and picture B on your notes. Okay, I want you to draw a presynaptic neuron with a long axon that synapses onto a postsynaptic neuron with a short axon. Okay? So do this activity right now. This is actually a pretty important activity. Right? This is going to set the stage for what you're going to do in SI, at least part of what you're going to do in SI. And then the second picture is just the opposite, short, long. A presynaptic neuron synapsing onto a postsynaptic neuron, and the first neuron has a short axon, and the second neuron has the long axon. So long, short, and then short, long. So what you're doing here is you're drawing a basic peripheral neuronal pathway. One is a parasympathetic pathway, and the other one is a sympathetic pathway. So which is which? Which of the two drawings, A or B? Picture A, remember it's long, short. Picture B is short, long. Which one is a sympathetic pathway? By design, by makeup. How many of you think A? How many of you think B? Okay. There's a lot of people not playing today. Okay, I see that. So, pathway B. Pathway B is a short neuron synapsing onto a long neuron. That is a sympathetic pathway, pathway B. Relatively short preganglionic fiber and a relatively long postganglionic fiber. Now, what was the definition of a ganglion? It's a biological mass of tissue that's usually a collection of nerve cell bodies. Right? So this architecture is important. This architecture is important, and we're going to spend much of today talking about this architecture. But before we go there, and we're going to do some drawing activities, because I think drawing it out beyond what you've just done is a great way to study. In fact, I get a lot of questions from you all about, I don't know what to do. I'm not doing as well as I'd like, and I'm trying to figure out some study tips. So I'm giving you all some study tips on this particular section. And a lot of it involves drawing out these pathways. Okay, and I would encourage you to draw them out many times. Do it a lot. You know, not just the night before the exam. You could create flashcards. If flashcards don't work for you, folks, then don't do them. There's nothing magical about flashcards if they don't work for you. Right? If the psychology makes you feel like you're actually studying better by making them, okay, fine. But, you know, maybe just put a tape on before your tape. Hit play on your MP3 player before you go to bed and record yourself saying, I am good. I am smart, right? And people like me. Turn to the person sitting behind the person in front of you and say these words. I can do this. Okay. If you didn't follow that, that's actually yourself. Okay. So before we go to the drawings, and before we dive into how we're going to organize these different pathways, let's talk about the diversity within the peripheral nervous system. Now, a while back, I described the synapse, and we talked about how there's a lot of biological energy, and what that means. Does everybody understand what the word, when we say biological energy, what does that mean? What's that? Membrane potential? Okay. Just more generally, even not very specific. ATP, okay, you're talking about ATP. When we say biological energy, we're saying if you see something within an organism that exists, it was purposefully put in place, right? It's serving a purpose. And there was energy required in order to make that happen. So biological energy is saying, if you're going to have a neuron, for example, and you're going to wrap it with myelin, well, there must be a value to wrapping it with myelin, because it actually takes biological energy to make the myelin. Right? You know, energy doesn't come from nowhere. So if you have, neither does matter. Right? Remember the cell theory? Cells arise from pre-existing cells. So, I mean, energy and matter are not created nor destroyed. They just move from one form to another. So if you see something that exists biologically, it probably has a purpose. Okay? So if we have a synapse, we have a neuron coming out, we have a gap, and then we have another neuron, and there's an actual gap right there, and we have a neurotransmitter, that's a lot of stuff happening, right? The exam would be a whole lot easier if there was no synapse. You with me? You're like, yeah, why couldn't it be that way? But because there's a synapse, now we have to study all these different things that can happen at the synapse. Well, we said, why would you spend the biological energy creating a gap where you have one neuron, a break, and then a second neuron? And we said things like, it allows for control. You can turn on or off the signal. It allows for variation. You can get different types of signals. Now, we're in no way going to cover all the different varieties of the signals. We're going to cover a few of them, okay, that cover a vast majority of what we use. So the neurotransmitter that the autonomic nervous system most commonly uses, that includes the parasympathetic and the sympathetic under that branch, is acetylcholine. And that's why we always talk about acetylcholine. It's the #1 used neurotransmitter. Okay, it's like Google's the #1 search engine. I just went off, didn't I?
Yep.
Am I back on? No? Ooh, there we go. Okay.
I don't think it's close enough to you.
You don't think it's close enough? Is that better? Okay. So the #1 neurotransmitter that's most commonly used is acetylcholine. And when we think about fibers, neurons that are going to manufacture and release acetylcholine, we call them cholinergic fibers. And you can remember this, if you make a flashcard, you can remember this as cholinergic fibers release acetylcholine, right? So the word choline is within that word. And maybe that will help you remember. Cholinergic fibers manufacture and release acetylcholine as their neurotransmitter. This is found in both the sympathetic as well as the parasympathetic. It's more dominant in the parasympathetic side, but it doesn't mean it doesn't exist in the sympathetic. So we could actually stop there and say that we've covered a vast majority of the neurotransmitter signal that's being performed within the body. But we won't, because there's other diversity that's important, and there's certain ones that you're going to need to know for next semester for 202. And so that's the reason we can't stop right there. Okay? That would be a 100 level class. But in a 200 level class with a follow-on 202 semester, next semester, we need to talk about some of the other ones. This acetylcholine, though, is broken down by an enzyme known as acetylcholine esterase. It's abbreviated ACH with a capital E. Capital A, lowercase ch, and then a capital E. Acetylcholine esterase. Most things that end in ACE are proteins, and they're usually enzymes. So the acetylcholine esterase rapidly breaks down acetylcholine in that cleft and keeps it from causing a response. Now, when acetylcholine is in the synapse, or the gap, or the chasm between one nerve and another, it's going to bind on the postsynaptic side to what we call receptors. Right? And these receptors that bind acetylcholine are conveniently referred to as cholinergic receptors. So our fibers that manufacture and release acetylcholine are called cholinergic fibers. Our receptors that receive the acetylcholine as it crosses over the synapse are known as cholinergic receptors. Now, under this broad family of cholinergic receptors, we have two main types that we're going to study. We have nicotinic receptors, which are our first type of cholinergic receptor. So a nicotinic receptor is going to bind acetylcholine, and it's going to cause, if you remember back to our last unit, acetylcholine as a neurotransmitter is an ionotropic or a metabotropic type of neurotransmitter. It's an ionotropic. Now, why would it be an ionotropic receptor? Because it directly causes a change in membrane potential. So, in fact, down the middle of the acetylcholine receptor, known as the nicotinic receptor, here's our nicotinic receptor. You can see that this gate is closed. When acetylcholine binds, the gate opens and it allows sodium to come into the cell. And that's how it directly causes a change in membrane potential. Okay? Well, why is it called a nicotinic receptor? Well, it was originally discovered and studied in a laboratory that was doing some work on nicotine. And they discovered that this receptor responds to nicotine. So the nicotine, the compound, the drug that's found in lots of different things, but primarily it's found in gum, right, that you buy, nicotinic gum. Cigarettes, right? Tobacco has nicotine within it. And so the nicotine molecule binds to the nicotinic receptor, which is a type of cholinergic receptor, and it causes an action potential. And so if you know, folks, or if you use tobacco products, right, sort of the feeling or sensation that you become accustomed to with nicotine is this compound binding to receptors and stimulating an action potential. Okay? Some of them are sensory. Some of them stimulate action potentials into the pleasure center. That's actually one of the reasons nicotine is so addictive, is it actually has a direct stimulation into the limbic system, and you actually have this emotion of pleasurable response. Now, nicotinic receptors are excited by acetylcholine, and the autonomic nervous system that responds are going to be the ganglia, the adrenal medulla, and skeletal muscle. Right? The adrenal medulla releases what compounds? Adrenaline. and noradrenaline, epinephrine and norepinephrine. Now, our second type of cholinergic receptor is referred to as a muscarinic receptor. Now, likewise, in the laboratory, scientists were not all that creative at some level, right? For example, with naming things. So this was research that was being done on a mushroom toxin called muscarine. And that mushroom toxin actually has an affinity for this cholinergic receptor, so it was conveniently named a muscarinic receptor. But this muscarinic receptor has sort of two types of activities, and you can see in this picture the stimulatory subtypes and the inhibitory subtypes. So the stimulatory subtypes are the odd numbers, M1, M3, and M5. These are not BMW models. This is a type of muscarinic receptor. And then 2 and 4 are inhibitory. So here you're already now starting to see the diversity in just one subclass of neurotransmitter receptor. Right? Within our muscarinic family, we have 5 different subtypes of muscarinic receptors, M1 through 5. And the odd numbers 1, 3, and 5 are stimulatory when acetylcholine binds. And it's inhibitory if you bind acetylcholine to a 2 or a 4 subtype. Make sense? So now you have the same neurotransmitter with a different receptor causing completely different responses. Excitatory in one, inhibitory in another. Is it important, Dr. Keller, that I know which ones are stimulatory and which ones are inhibitory? What do you guys think?
Yes.
Yes, it is. Okay, because this would be a great test question to understand if you see the diversity within the system of using the exact same neurotransmitter but binding to a different receptor, you're going to get a different response. How different? In some cases it stimulates, in other cases it actually inhibits. So if we look at the examples are if acetylcholine binds to a muscarinic receptor in the intestine, it stimulates the intestine. It stimulates GI motility. So if you stimulate GI motility aggressively, what is the clinical response? It's not a trick question. What do you guys think? If things are moving through the intestine too fast, and you're always having to get up to go to the restroom, what's going on? Diarrhea, right? Yeah. It's not. I mean, diarrhea happens, right? That should be a bumper sticker. So, in the case of a muscarinic receptor, right? Muscarinic receptor that is binding to the intestines, if it's in stimulatory type, it would be what? M1, 3, or 5 that's found in the intestines. And that causes an increase in GI motility. If it goes too much, then the patient has diarrhea. Okay? If it's cardiac, the cardiac must be 2 and 4 because when acetylcholine binds to cardiac muscarinic type of receptors, it's inhibitory. And that actually slows down heart rate. And that would be an example of an M2 or an M4. Okay, so you're going to find muscarinic receptors in the intestine as well as in the heart. So let's ask you this question. Let's just see how you're processing this information. When the parasympathetic division is stimulated, what neurotransmitter is released at the effector organ? When it's stimulated. And it's a neurotransmitter. What's the only one we talked about? Acetylcholine. Thank you. Hey, nicely done. You guys are brilliant. Okay. Let's talk about our second type of receptor. First type was muscarinic. Our second type is called adrenergic. Adrenergic. Now, want to bet we're going to have a couple of different types of adrenergic receptors to go through?
Yeah.
Okay. Yeah. You bet. I'm so excited you guys are wound up about this. So, the adrenergic family of receptors the nerve fibers are going to release a neurotransmitter, and the receptors are going to bind that same neurotransmitter. And the neurotransmitter that we're going to be responding to is norepinephrine. Norepinephrine. So norepinephrine is going to be binding to adrenergic receptors. Well, what about some mnemonic, like you did with the other one, to help us remember? Acetylcholine binds to cholinergic receptors. Well, what's another name for norepinephrine? Noradrenaline, right? So noradrenaline binds to adrenergic receptors, right? Adrenergic, the root coming from the adrenaline compound. Okay, so likewise, like we saw with our cholinergic receptors, we're going to see a couple of different subtypes. We have the first one that we refer to as alpha, and the second one, what do you think it's going to be called?
Beta.
Beta, you're right, because now you can predict the mind of a scientist. What would be the most accurate but yet boring name for the next subtype, right? Beta. So the alpha, we're going to further discriminate between alpha 1s and alpha 2s. And then we're going to see sort of our diversity within this biologic response. So in our first example, the alpha adrenergic receptor, like the alpha 1 that's shown right here on this sort of middle column here, if you will, of the slide, or the far left of the right figure, our alpha 1, when stimulated, is going to cause smooth muscle contraction and vasoconstriction. And typically, norepinephrine or noradrenaline is going to be excitatory with alpha adrenergic receptors. So you can see through the alpha 1 that you get a smooth muscle contraction, and if you're within a blood vessel, that's going to cause vasoconstriction. Likewise, if you see an alpha 2, it also will stimulate muscle cell contraction, but in an alpha 2, it may be found outside of the vasculature. It might be found in another smooth muscle type of muscle tissue, like within the gut, for example. Okay? Now, our second family is known as the beta adrenergic receptors, our beta family. And that's this far right pathway over here. And we have excitatory pretty common with the alpha adrenergics. Down here, these guys behave very similarly to our second muscarinic type of cholinergic receptor. We get sometimes it goes inhibitory, and sometimes it actually goes stimulatory, right? So, for example, it usually is going to be inhibitory, but if we have a subtype known as beta 1s, and you bind norepinephrine to a beta 1 receptor, which is a subtype of an adrenergic receptor, the response that you get with the beta 1 is that you increase heart rate contraction. Okay? If you bind norepinephrine to a beta 2 that you find within the respiratory network, you're going to cause relaxation of the airways known as bronchodilation. So I want to use an example here, a clinical example that I think may hit home with many of you. And the reason I think it may hit home is either you have one or you know somebody that does. How many of you know what this is right here? Okay? What is it?
Inhaler.
It's an inhaler. Okay? This inhaler is a beta agonist inhaler. Okay? So this is going to cause stimulation of beta receptors, this little inhaler. Okay? And when you have a hit of this, or a puff, right? Let's look at the clinical pharmacology that's coming out of this little package insert. So this is the little insert that, I mean, if you're a nerd, then you save this thing, right? Yeah. And then you get excited about, that organic chem right there, and then you read this section right here. Instead of throwing this in the recycle bin, as you unfold it 75 times when it comes out of the package, You actually save it as an example. So let's read this together of a beta type of agonist. And it's trying to stimulate which beta receptors? 1 or 2 on the in the respiratory bronchi?
2.
Type 2. Okay? So the prime action of the beta-adrenergic drug is to stimulate adenylene cyclase, right? And then go down here to the second paragraph where I underlined in vitro studies. In vitro studies, which is code word for benchtop studies, and in vivo pharmacological studies, this means in probably animals as well as humans, have demonstrated that albuterol has a preferential effect on beta-2. Can you see the subscript?
Barely.
Barely, huh? Hang on. I mean, the cool thing is look at this. I mean, is that like ridiculous?
Oh. Yes. Oh.
Can you see it now?
Yeah.
Beta-2, right? Okay. Can I zoom back out?
Yeah.
Have you ever walked into somebody's office that has their word turned up to like 300%? That's what that felt like. Okay. So now we know, we agree that these are beta-2s. We probably could have just looked right there because it's a little easier to see. On beta-2 adrenergic receptors compared with isoproterenol. While it is recognized that beta-2 adrenergic receptors are the predominant, what's the word predominant mean? The main, right? They're the main receptor in bronchial smooth muscle, aha, or in the lungs. Data indicate that 10% to 50%, that's a large range by the way, of the beta receptors in the human heart may be beta-2. The precise function of these receptors has not been established. Albuterol has been shown in most controlled clinical trials to have more effect on the respiratory tract, right? Comparable doses while producing fewer cardiovascular effects. But what is the side effect of having albuterol? Racing heart rate. Okay? So it's less obvious with a little inhaler because it's a small dose. It's more obvious if a patient's using a nebulizer treatment. Okay? That's that little machine that plugs in the wall. Looks like, they're on a bong and they're an asthmatic. Okay? And it's like aerosoling, it's blowing air into a solution and it creates an aerosol type of mist, and that creates an airborne, inhalable albuterol. And they sit there for about 10 to 15 minutes on this machine and probably alleviates a trip to urgent care. But one of the side effects is rapid heart rate. Okay? And it's because of this clinical pharmacology that's found, it's like this little prize in the Cracker Jack box. Right? You guys should read these things when you open up your medicine. It's actually kind of cool. Okay, does this make sense? Does this example make sense?
Yes.
So if you have a beta agonist, a beta-2 agonist that's very specific, unfortunately in the heart, we have 10 to 50% of beta-2s. It's not just a population of beta-1s. And that's why our side effect of taking albuterol, or a patient having albuterol, is a racing heart rate. Okay? Yes?
Does that mean that in the cardiovascular system, the beta-2 is excitatory instead of inhibitory?
In the beta-2 cardiovascularized, yes. If you look over here in the beta-1s, it also has the same effect. So what we discovered within the heart is the receptors that are beta receptors in the heart are not 100% beta-1s. So the beta-1s and the beta-2s in the heart actually have a similar type of activity in the heart, and that's why you're getting this sort of side effect. Now, the other one that I don't have an example of, but I can tell you about it, are called beta blockers, since you brought it up. I know you're interested in cardiovascular, so you don't have to wait until next semester. We'll talk a little bit about cardiovascular. So on the heart, as it relates to this slide right here, okay, if you have a patient that's in heart failure, okay, let's say they need a valve. Okay, let's say they've had an MI, a cardiac infarction, myocardial infarction. And their heart is weak. And so what you want to avoid is you want to avoid their heart being overly active. And so you'll put them on what we call a beta blocker. Okay? It's a drug. that blocks beta adrenergic receptors. Now, you explain to me why a beta blocker for the heart would be advantageous for that patient. If you don't want the heart working, what are you worried about? The heart works too hard and you have another heart attack. Okay? It's like if you drive an old car. Okay? You have 300,000 miles on it and you're coming up from Phoenix. Are you going to even attempt to go 75 miles an hour uphill? No. Right? You're probably going to pull over, go to the bathroom a couple times, have a Starbucks stop, right? You're going to have your blinkers on in the shoulder, right, as you're driving up. So you're not going to overdo it. That's the same thing. If you have a compromised heart, like a compromised engine, you do not want that heart rate to get too fast or high. So why would you put them on a beta blocker? Tell me which pathway you're regulating. Just looking for a volunteer that's not thinking about making a snowman. I just distracted like 70 of you. Sunshine. Yes, sir?
I want to increase the parasympathetic. I need to decrease sympathetic.
Well, you want to increase parasympathetic if possible. But with respect here to our beta receptors, right? A beta blocker on the heart is going to do what? Which receptor type is it primarily going to be targeted toward? B1s. You would want to put a B1 beta blocker into that patient. You with me?
Yes.
Okay. Because if you used a broad-based beta blocker and it had activity on B1s and B2s, right? And let's pretend for argument's sake the heart is really only 12% B2s, right? And it's 88% B1s. Then you do not want side effects on the airways, right? If you block a B2, then you could actually have a side effect in the patient of wheezing, and they never had any respiratory problems. Okay? So the clinical pharmacology, the reason I walk through this is many of you are going to be nurses, doctors, physician's assistants, right? Or even researchers. And when you research a drug, you need to understand what those side effects are. And those side effects are based upon their mechanism of action. So if you're going to be working in cardiovascular medicine, or cardiovascular research, and let's say you're synthesizing drugs, you need to understand how specific their response is and what those side effects are going to be. And that's why when you turn over the package or when you listen to the commercial and they talk about all these known side effects, that's where a lot of this stuff comes from. Okay? All right, so our second example of a different type of receptor. Now, if we compare and contrast, you guys know I like setting them up like this. I like setting up these types of tables because I think it helps you compartmentalize or categorize how these things look. If I look at the sympathetic division, our preganglionic fiber is always cholinergic. If I look at our postganglionic fiber, it's mostly adrenergic, and in some cases, it's cholinergic. In addition, if I look at the parasympathetic side, right, the rest and digest side, I always see a cholinergic fiber releasing acetylcholine, and then I always see a cholinergic fiber releasing acetylcholine on the postganglionic side. So if I take this information, we could actually design out your drawings in a little bit more detail, and that's what we're going to do here in a minute. But before we go there, let's look at this question. When norepinephrine binds to the beta-adrenergic receptors on the bronchioles, you're not going to get bronchioles until 202. That's the respiratory system, but I just told you what they are. It is most likely binding to which of the family of beta receptors?
B2.
B2. That's our little inhaler example. Okay? I could equally ask a question about a beta blocker type of drug on the exam, because we went over those examples, right? And that would be the B1 primarily. Now, what I want you to do next, I'm going to look for some volunteers. So draw this out as if, Mom's going to hang this on the fridge. Okay? You're like, we got a stainless refrigerator, so nothing sticks to it. Use tape, okay? Yeah.
What would be a situation where you need a B2 beta blocker?
A B2 beta blocker. I can't think of an example of why you would want to restrict the airways. You know, most of the diseases, even like emphysema, as well as bronchitis or bronchiectasis, all of these diseases restrict the airways. So you want to dilate them. You don't want to, close it off. I can't think of one off the top of my head. I'm sure one exists, right? And I'd have to do some homework on it. So draw a generalized parasympathetic pathway and label the following: nicotinic receptor and muscarinic receptor. And then draw a generalized sympathetic pathway and label nicotinic, adrenergic, and muscarinic. Give it a try.
This would be our this one, but I don't know if you think about it, it would be like, so this is our acetylcholine, and once acetylcholine binds to the nicotinic receptor,
How are you guys doing? So-so? So-so. Okay, that's a fair answer. That's better than terrible. Maybe it's blind. You guys really doing terrible?
Yeah.
You are? Oh, look how honest you are. Right, that's what's wrong with America. Hey man, how you doing? Great. Awesome. How are you? Awesome. Both guys are like having the worst day of their life. Right? We don't ever say anything other than, oh yeah, I'm doing great. Are you guys really bad right now? You're not doing good with this? Do you guys have any clue what I'm asking?
No.
Really? Okay, those of you that said that, now that we're being honest here, how many of you looked at the lecture before you got here? Okay, like 7. Sweet. Not so great. How many of you looked at the chapter before you got here? How many of you relying on Keller to teach you everything you need to know? Yeah. Okay. So this is not a snail with a long neck. That's what my kids thought it was. This is a beginning of a generalized parasympathetic pathway, right? Because it goes long and then short. That's a neuron. In case you're like, so what is it then? It's not a snail with a long neck. It's a neuron, man. Okay? I'm a scientist, not an artist. Okay? Now, in comparison, you're like, yeah, this is why we like classes that have PowerPoints, Keller. Yeah, I know, but I'm trying to mix it up. This is the beginning of a generalized... What? A generalized sympathetic pathway. Because it goes short and then long. I like hitting that automatic focus button, but it didn't do anything at the bottom. Oh yeah, that's a little better. Okay? So on the top one, you should be able to draw a short fiber that looks like the bottom one. And on the bottom one, you should be able to draw a long fiber after it that looks like the top one. You with me? And then you're going to have to draw this one on the bottom again. You need to actually draw 3 setups. A generalized parasympathetic fiber, and then 2 pathways that we're going to flush out for our sympathetic fiber. Is anybody feeling comfortable to come up here and draw this out? I mean, if you're not, then I will show you what I'm looking for, and I will ask you guys on Thursday where you're at, okay? Okay. So, if you
Yeah.
draw out our parasympathetic pathway using these little cartoon drawings. The reason I wanted to do this, I wanted to prove to you that you can draw it. I mean, if I can draw it, these are like stick figure neurons. Okay? I know, if there's an artist in the room, I totally apologize. Okay? This is why when I wrote my last textbook, I hired an art team, because that's what you guys would get, right? And then imagine like trying to, teach the muscles with stick figures. That would really suck, right? But if you're trying to figure out how this works, I think this will be valuable to you. So here's our parasympathetic fiber. Here's our postganglionic neuron and our preganglionic neuron. And you know that according to our table, right, we go always cholinergic, parasympathetic. So if it's always cholinergic in both locations, then you're going to have acetylcholine as the neurotransmitter in both synapses, right? So if you have acetylcholine as the neurotransmitter in both synapses, here we have a nicotinic receptor, and here we have a muscarinic receptor, right? This is the parasympathetic side. And here's our target cell. And you can see up here in the upper right, this is the only version of the parasympathetic fiber schematic that you actually have. You use acetylcholine in both locations, and you use a nicotinic receptor here and then a muscarinic receptor there. Now, if I switch over to the sympathetic side, this is shown in your textbook, and I'll show you the textbook pictures. Okay, but I think the Keller's chicken scratching is helpful, because then it'll make you believe that you can do it. And I know you can, actually. In fact, I know that you guys will be able to draw this way better than me. You could totally take pictures of the screen if you want. So this is the most common type of sympathetic fiber. It's called a sympathetic adrenergic fiber. And the reason that we call it sympathetic adrenergic is because the fiber is releasing what? Right? Well, this one's releasing acetylcholine, and what's this one releasing? Norepinephrine or noradrenaline binding to an adrenergic receptor on the target cell. So this is the more common pathway that you would see. Short, long, but you have some uniqueness here where you have norepinephrine as your secondary neurotransmitter. If I contrast this to our more rare situation, and the difference between these two is actually the same here, it's the difference at the second synapse. Instead of norepinephrine, you use acetylcholine. And by using acetylcholine, you're binding to a muscarinic receptor, and this is our second, but more rare, not as common, sympathetic type of pathway known as a sympathetic cholinergic fiber. So parasympathetic has one pathway, and sympathetic has two possible pathways. And this is the same information that's presented on this table. Okay? So this table, you can see parasympathetic, there's only the option of cholinergic in both synapses. Sympathetic is always cholinergic, right? Using acetylcholine. And then you've got the option of using norepinephrine or acetylcholine in our second synapse. Yes?
So the only difference between the second example of the sympathetic that you showed is that it goes from short to long, compared to long and short for the parasympathetic.
Yep. This is short to long in both my third and rare example, as well as in the more common example, still short to long.
I'm sorry, I meant like, so, but the pathway is the same for parasympathetic with the other sympathetic. The only thing that's different is that it goes short to long, compared long to short.
Yeah, so you want to compare this is probably going to confuse some people because we're flipping slides too quickly. But you want to compare, that's okay. You want to compare this setup where it's acetylcholine and acetylcholine in a parasympathetic fiber to the more rare circumstance in a sympathetic fiber where, yes, it's acetylcholine, acetylcholine, but this is a short fiber here versus a long fiber. That is correct. Okay. It's a different pathway. It's a totally different road, if you will. Okay? So being comfortable and familiar with these three different pathways that are really this table. Do you see how they're this table? Okay. Some of you think just fine in a table. And therefore there's a table for you. Okay? Others require a picture. And I think that for those of you that require a picture, and even for those that don't necessarily need a picture, drawing it out might be helpful versus just staring at it in your book or looking at a slide. So my goal was to have someone come up and draw out those pathways. But instead of sitting here for the remainder of our class period waiting for a volunteer and then worrying about if I called on somebody if we'd have to resuscitate, let's just pause and do this Thursday, okay? But now you know what I'm going to ask on Thursday. You with me?
Yes.
So, we just did this activity. It would have been a colossal failure if I didn't come prepared, right? But, here are the pictures from the textbook. Like, oh. Yeah, you're like, oh, those are way nicer than yours. Yeah, I know, but I don't draw like that. Okay? I already told you I suck at drawing, okay? I'm good at other things. So here is our parasympathetic fiber. Just one last time. You've got your preganglionic fiber. You're like, that totally doesn't look like a snail color. Yeah, I know. Okay, but you saw my interpretation. Here is a short postganglionic neuron or fiber. You've got a nicotinic receptor on this side, receiving acetylcholine. You have a muscarinic receptor on this side, receiving acetylcholine. Yeah, I copied them from the textbook when I drew it, okay? But I was just trying to demonstrate that you could actually do it too. And here are our two different options that we just went over. Right? Our two different options that we went over. And they're not labeled as such. This one is the more common, and this is the more rare. Right? So here we've got short, long. We got acetylcholine and then norepinephrine. Here we've got short, long, and we've got acetylcholine and acetylcholine. Okay, you guys with me? All right. So to wrap up that component, let's take a peek at this question, and let's answer the following. During a fight or flight response, which type of receptor in the piloerector muscles, right, respond to the released neurotransmitter? Now, piloerector muscles are what type of muscle? What type of muscle are they? They're smooth muscles. So A, alpha adrenergic, B, nicotinic, C, beta adrenergic, D, muscarinic, or E, cannot determine. How many of you would say A? How many of you say B? How about C or D? Okay, or E? So alpha adrenergic is the correct answer. Because those are the ones that have the stimulatory effect that we talked about. Okay? So now that we're all tracking with that, do you guys remember this picture? This diagram?
Yes.
Yeah? So let's remind ourselves, focus on these three boxes. Right? We've got three different network pathways. Right? We had this information. We saw that this information included our synaptic pathways that were spinal, sympathetic, and splanchnic. So I want to pull this information back because I want to ask you this question. I'll come back to this picture if you need. You're running away from someone with a hatchet. Okay? Is this sympathetic or parasympathetic?
Sympathetic.
Most likely sympathetic, right? You're not going to stop and have a snack. Which is a correctly ordered pathway of neurotransmission that's taking place. Right? I would have liked to label this pathway the oh crap pathway. Right, so A, you've got splenic nerve to the collateral ganglion to the skeletal muscle. B, you have the paravertebral ganglion to the sympathetic nerve to the skeletal muscle. So does it go to the skeletal muscle? Most likely, because you're going to run. You with me? But you can't have this pathway and that pathway, so something must be wrong there. You with me? The ventral root ganglion, spinal nerve to the heart wall. Well, do you think your heart rate's going to increase? Oh, yeah. But is that the right pathway? Paravertebral ganglion, spinal nerve to the blood vessel wall. Are the blood vessels going to be involved? Well, yeah, if you need more blood flow, right, to the exercising muscle. So far we haven't eliminated any of the options. Paravertebral ganglion, splenic nerve to the hands and the feet. Okay, you're probably going to be running going, oh, oh, right? So I'm not sure we can eliminate any of those just based upon the end destination. But if you back up to this information and you think and consider these little boxes, right? Now, which pathway? If you have your slide in front of you, I could stay on this and you could walk yourself through. Need a little time? Talk amongst yourselves. Go forward and then back, or back and then forward. Okay, let's go back.
Spinal nerve.
And then you want me to go forward? So can you put it on the same slide, please? By the way, in the exam, I won't be going back and forward. I never do that, right? We've done 3 exams, and I'm never going back and forward for you. So you're going to have to remember this. So let's walk through it. How's that? Each option. So splenic nerve, collateral ganglion, skeletal muscle. Right? Splenic nerve. Where's the splenic nerve? It goes to the collateral ganglion. That's correct. Does it actually go to skeletal muscle?
No.
No. That's this one over here, right? That's which? The spinal nerve. So we know that A is not correct. Paravertebral ganglion, sympathetic nerve, skeletal muscle. So skeletal muscle is where we want to end, right? And we work our way backwards from skeletal muscle. Sympathetic nerve, paravertebral ganglion. Sympathetic nerve. Is this the sympathetic nerve? No, that's up here. So we know that B is not correct. Ventral root ganglion, spinal nerve, heart wall. So let's go to the heart wall and see if the spinal nerve works for the heart wall. Where's the heart wall? Thoracic should be up here, right? Heart wall. Is it the spinal nerve? No, so it's not that one either. D, paravertebral ganglion, spinal nerve, blood vessel wall. Let's go to the blood vessel wall, go backwards and see if it's the spinal nerve. You want to go with me?
Yeah.
Okay. Blood vessel wall, go backwards, goes to spinal nerve. Ooh. Okay. Now where? Ventral root ganglion.
No.
Right? Oh, sorry. Paravertebral ganglion. Right? Paravertebral ganglion. What's this one right here? What are these right here?
Sympathetic.
Right? This one is the paravertebral ganglion, just so you guys know. Okay? Let's check this last one. Paravertebral ganglion, splenic nerve, hands and feet. So we go hands and feet. Where's hands and feet? Let's see, it's going to go down, so it's probably, yeah, it's going to go this direction, okay, downwards, right? This is liver, spleen into the gut. So if you work backwards, is it splenic nerve? Oops, sorry. Right? It is splenic nerve, but it's not paravertebral ganglion, right? It actually comes in through this route. Okay, so the correct answer would be D. Actually, it doesn't go hands and feet. It goes to the gut, right? So hands and feet wouldn't be on the list. So it's not going to the hands and feet, it's going to the gut. Sorry, I misspoke on that one. So if you work through the pathways and you know them backwards and forward, on the exam you'll be able to identify which is the correct pathway that's being used. You with me? So on this last one, just because I probably confused you, paravertebral ganglion, splenic nerve, hands and feet. It's the splenic nerve, but hands and feet aren't on the list, so it doesn't go to the hands and feet. It only goes to what's listed here on the box. So if we look at our autonomic nervous system, and we consider dual innervation or innervation by both the parasympathetic side as well as the sympathetic side, the question that I want to pose to you is, do we have to have dual innervation happening all the time?
No. Yes.
It does happen much of the time, but it doesn't always have to happen to get the desired effect. This example is an example where we do see dual innervation happening in the body. Okay, when we talk about innervation to the pupils. So, for example, we've got both sympathetic and parasympathetic pathways coming from the brain and innervating into the eye muscle, right? That opens and closes the pupil. It allows for the amount of light to come in. And in this example, with the pupil, we see antagonistic effects. What that means is one does one thing and then the other one does the opposite. If one does one thing and the other one does the opposite, then these would be working in opposition or antagonistic. So for example, if we follow this yellow pathway of sympathetic fibers, these sympathetic fibers come in here and stimulate a dilation of the pupil. Likewise, the blue parasympathetic fibers through this ciliary ganglion actually stimulate a constriction of the pupil, or a parasympathetic response. So one pathway allows more light in, the other pathway allows less light in. We have a second example of dual innervation that's with saliva. And with saliva, we have what we call agonistic effects. Agonistic effects mean that they work together. Both the parasympathetic and the sympathetic system are going to be cooperating in order to release an appropriate composition and amount of saliva. So for example, they act on different target tissues, right? So our target organ is something else, but both pathways are going to be running. So if we look at our parasympathetic pathway, then we stimulate watery secretions to take place. The watery secretions are rich in digestive enzymes, right? The things that break down the food that's within your mouth. And then the sympathetic nervous system, this is going to act on the salivary glands to release a mucus compound. And the enzymes are going to get bound up in the mucus, and then that sticks to the food, and it allows it to actually chemically break down the food. So salivary glands are the target of the sympathetic nervous system, and other glandular secretions that produce enzymes into the saliva are part of our parasympathetic response. So the kind of crazy example that I like to use here is so that you guys remember it, right? So patients that abuse meth. How many of you have heard of Meth Mountain? You've seen the posters or the public awareness campaigns, right? So what's going on with these patients? Well, a methamphetamine is going to stimulate the sympathetic nervous system. So you get bruxism in the patient. Bruxism is a clenching and a grinding of the teeth, right? And you're going to have oral or hygiene because, you know, they're running around doing something and they're not going to stop and floss, for example. You get hyposalivation, under salivation. Why under salivation? because it's the parasympathetic response that's going to create the saliva that has the enzymes. And the mucus is being released by the sympathetic system. So the mucus that's being released is going to stick to the teeth, right? And then any enzymes throughout the day that are released during a meal or whatever are going to be kind of rotting away the enamel of the teeth over time. And so the result, right, of meth mouth is a stimulation of the sympathetic nervous system with bruxism, clenching and grinding of the teeth, hyposalivation, so you're stimulating mucus to be released and not necessarily more water. And this is what it looks like. Now I posed the question as we started this segment. I posed this question of, does dual innervation by the sympathetic and the parasympathetic, we had two examples. We had the eye and we have the salivary glands, if you will, in the mouth. Now, it doesn't always need dual innervation. So the answer to this question is no. It could actually only be one or the other. And so, for example, this is what's happening within your vascular network. So your blood vessels don't have any parasympathetic innervation. They only have sympathetic outflow. And this picture is showing a sympathetic nerve fiber that innervates a blood vessel. And these little lines through the nerve fibers signal what? What do those little hash marks signal in nerve physiology? We just had an exam on this. No, not nose of Ranvier. This is indicating the number of action potentials. Okay? So, do you see that there are more here and there are fewer here? So, if you send consistent action potentials to this nerve, it's going to cause vasoconstriction. If you back off and send fewer action potentials, right, then the blood vessel by nature is going to dilate. So this is an example where you can have control of an organ or a target tissue with only one component of the nervous system. It doesn't have to be dually innervated. Now, our last question of the day, and then I'm going to wrap up. You've just had lunch, you're beginning the process of digestion. Which type of receptor in your heart wall responds to the released neurotransmitter? A, adrenergic, B, nicotinic, C, beta-adrenergic, D, muscarinic, or you cannot determine. Who's got an answer? Yes. D, muscarinic? Yes, absolutely. Sweet. One person gets it today. Nicely done. Okay? So let's wrap up for today. I want to bring you back to what we've already talked about in our closing minutes. So the autonomic nervous system isn't operating all by itself. It's under control. Right? It's under control and influenced at some level by the cerebral cortex. Right? This is our conscience that interacts with the limbic system as well as the hypothalamus. So, hypothalamus for things that we need to survive, and the limbic system for emotions and memory. It's under control by the hypothalamus, right? Things like hunger and thirst, things that we need to survive. The autonomic nervous system doesn't operate all on its own. If we move down a little ways, right? Remember all these nerves? The cranial nerve nuclei are fully in effect as a part of the peripheral nervous system. So we've got our pupil constriction as our example today, controlled by oculomotor nerve 3. We have the facial nerve 7 that's responsible for our example with our lacrimal, salivary, and nasal secretions, right, in our dual innervation. We also have the glossopharyngeal nerve that's in operation for salivation in our dual innervation. The thoracic and the abdominal viscera are controlled by cranial nerve 10, our vagus nerve. So our autonomic nervous system in the periphery is fully influenced by our central nervous system and the outflow of the CNS being these cranial nerves that you learned about even in laboratory. And then the spinal cord, as we move further down, these are things that are reflexes, usually. Right? They're reflexes because you don't have to think about it. Many times, most of the time, hopefully right now, you can consciously inhibit either one of these activities if that's what you're rushing to get out of the room for. Okay? But the spinal cord, again, one of our axes, further down is automatic responses. So our last question, this one's an easy one. This is a softball toss. After you've read it, hold up your hand, symbolizing the answer to the question. This is our quick, right? You can go like this, right? I don't know. I wasn't in cheerleading stuff. Okay. See, everybody stand up. Let's vote. Ready? Come on. You guys want to go anyways, right? How many A's do we got? Okay, no, I got a motion in the back. Sweet. Okay, let's do A's. Okay, nobody's joining me. B's, C's, okay, D's, right? Fortunately, there's no E, but I think I'm doing like that, right? C is the correct answer, digestion. All right. Work on those activities. I'll see you Thursday.
One star is